Hi, good afternoon. Thank you for the opportunity to speak today. I'm a colorectal surgeon in the Center for Inflammatory Bowel Disease, so I have the privilege of sharing a wall with Dr. Desopoulos, which is a huge benefit for my patients with the multidisciplinary care that they get. So I wanted to. Just an overview, I will keep it short and sweet. Anatomy and principles of perianal disease. We're going to talk about traditional therapies and outcomes, both medical and surgical. We'll talk about stem cell therapy, which is really the cornerstone of what we can consider new therapy for perianal disease, and some clinical trials related to those. So the problem here is that perianal disease is such a common presentation for patients with Crohn's disease. In 10% of patients, it's a presenting symptom, and in 25% of patients with Crohn's disease, they'll have perianal disease. It's prognostic of more aggressive disease, and with all therapies considered, both medical and surgical, the overall durable remission rate is terribly low. It's 37%. The risk of proctectomy to patients who present with it is 8% in 10 years of disease, and it goes up to 20%, or almost 20% in 20 years of having disease. There is a very small risk of malignancy, but not zero. And really, more than anything, it's a source of disability, decreased quality of life. Patients are not able to hold jobs. They can't sit at a desk. They can't be intimate with their partners. And it's a problem that is chronic and keeps people in the both surgeon and GI's office. Anatomy and principles, there are two major classifications. The Park classification refers to both benign and Crohn's-related perianal disease. It's based on its relationship to the external sphincter. Superficial, intersphincteric, and transsphincteric cases can arise from both the dentate line or above or below those areas. In Crohn's disease, there is a high, although the most common is intersphincteric. In Crohn's disease, there is a chance that we can be dealing with extrasphincteric or suprasphincteric fistulae, which are extremely difficult to treat. The AGA classification divides them into simple versus complex, and in most cases, Crohn's disease fit the complex category, having either a high anatomical position, multiple sites, or related to other structures, including the vagina and strictures. The goals of therapy, ideally, we would like to shoot for definitive closure, which is inability to probe the fistula and resolution of the fibrous tract on MRI. That's not often the case, though. The rates that have been reported in studies ranges from 30 to 80% for definitive closure. They're sort of second to that and beyond our remission, which is closure on 2 exams, so it's short-term resolution of their symptoms, and improvement, which is a decrease of 50% in the amount of drainage on 2 exams. But really, realistically, what I tend to see in my office is what you see in the picture on the bottom right. It's symptom control and preservation of continence with multiple, basically, destination cetons. The traditional approach is medical therapy. There's not a lot of good quality evidence for antibiotics contributing to resolution of fistulae. The most recent that I could see was a placebo-controlled trial. Most recent of a control trial that I could see was a placebo-controlled trial conducted in 2009, which basically showed no difference in closure between Cipro or Flagyl or placebo. Thiopurines do contribute to a fistula response up to 50% in patients. And biologics, as Dr. Desopoulos touched upon, do have the highest chance of closure. Infliximab reports a closure of 55% at 3 months and up to 36% in long-term follow-up. It also supports fewer hospitalizations and surgical procedures, even if the fistula is present, because the degree of inflammation is controlled. Adalimumab has similar efficacy, and again, as Dr. Desopoulos touched upon, vedolizumab and ustekinumab are pretty early in their experience, and the patients that have been included in the reported trials that have fistula are small, so subset analysis doesn't really lead to significant results, but anecdotally, it may be that these are going to be promising therapies down the road. The surgical approaches include fistulotomy, which is discouraged in Crohn's patients. It is the gold standard for management of benign perianal fistula with 80 to 100% healing rates. However, that drops to 27% in the setting of active proctocolitis. And if it is a transsphincteric fistula, which is often the case, the risk of incontinence is prohibitive, so don't do it. Really what we rely upon now is a non-cutting ceton. It has the lowest risk of incontinence because we don't address the anal sphincter. It's tolerated fairly well by patients, so we use a narrow, usually a fairly inert, narrow vessel loop. And it does have a role in healing of fistulas in the setting of infliximab. That is better compared to infliximab alone. So in randomized controlled trial in 1992, the role of a ceton with infliximab allowed for better initial response in healing of the fistula, lower rates of recurrence in 3 months, and more delayed recurrence if it were to recur with the help of, with the help of a ceton in the setting of infliximab therapy. Fibrin glue and plugs are offered to our patients with Crohn's disease. However, they have pretty low success rates and high rates of early failure, mainly due to technical issues. There are some sphincter preserving techniques that we can consider for patients. The endoanal advancement flap is a partial thickness flap that addresses closure of the high pressure end of the fistula, so the intrarectal side. The healing rates are high in benign disease, 60 to 81%, but for Crohn's, where we rely on the integrity of the health of the distal rectum to heal that flap, that drops pretty low to 25 to 64%. When you're dealing with a full thickness flap, which includes mobilization of part of the internal sphincter, the incontinence rate can be as high as 10%. And of course, it's contraindicated in patients with active proctitis, and it's fairly difficult in patients with stenosis. So we're limited with that option in patients who have combined perianal fistula disease and proctitis. The lift procedure, which is ligation of an intersphincteric fistulous tract, is an option we can offer for patients, even patients who have some anal disease, because the incision is in the intersphincteric plane on the perianal skin and not involving the mucosa. The healing rates are very high in benign disease, again in that 60 to 80 range. There's limited experience of lift applied to Crohn's patients. The best data that we have is a series of patients, or 15 patients with Crohn's disease, where the healing rate was up to 60% in 2 months, 67%, so pretty durable in 1 year, and the incontinence rate is 0. There are some, so short of managing the activity of the disease, really those are the surgical options that we have. Really the goal, though, is to provide some immunomodulation of the fistula tract, and there's some data that is in its infancy with intralesional therapies, and that's what I'll talk about for the remainder of the talk. Intralesional infliximab is one of those. There's not a lot of data on this approach. Mainly the data is of small, non-controlled studies, but of course in selected patients you get the best outcomes, and healing rates have been reported up to 50 to 88%, anywhere from 3 weeks of follow-up, which doesn't really count, up to 12 months of follow-up. These small studies consist of a pretty heterogeneous group. Some are getting concomitant IV infliximab. Some don't have proctitis, some do have proctitis. So it's really hard to tell whether or not this is going to be a therapy to consider down the line. The administration was also heterogeneous. Some patients had injection of infliximab into the fistulous tract. Some had it circumanally. Some had up to 3 injections. Some had up to 10 injections. This was also sometimes combined with, fistulectomy. No, none of the patients had a fistulotomy, but combined with fistulectomy or sphincteroplasty. So it's hard to know which therapy is contributing to the most durable remission. Now to stem cell therapy. So stem cell therapy as a treatment of Crohn's disease came by somewhat as an accident. With the advent of stem cell therapy for hematological malignancies in the early 90s, we have some case reports of patients with concomitant Crohn's disease who actually saw a resolution or remission of their Crohn's disease following stem cell transplant. These 2 cases, one was a 41-year-old woman with non-Hodgkin's lymphoma who had longstanding perianal and colonic Crohn's disease, also experienced up to 6 months remission of her Crohn's disease. That was her follow-up, up to 6 months remission of her Crohn's disease following her stem cell transplant, which also cured her non-Hodgkin's lymphoma. A 20-year-old man had a similar presentation. He had longstanding penetrating ileal disease and perianal Crohn's disease, and he had much longer follow-up, had no active disease of his Crohn's for 7 years in the follow-up that he received both post stem cell transplant. It's not an easy therapy to undergo, however, and even in 2017, the non-relapse mortality of stem cell transplant is 3% in the first 100 days, 4% in the first year, and up to 5% in the first 3 years. So certainly not one we want to throw at every patient with Crohn's disease. Nevertheless, my title is cut off, but nevertheless, it is an approved therapy for Crohn's disease in Europe as of 2012 for those patients meeting the below 3 indications. So those that have active or unresponsive disease, those who have extensive, typically small bowel disease where surgical resection would put them at undue risk for short bowel syndrome, and those with refractory colonic disease where stoma is not acceptable. Notice that perianal fistulizing disease is not an indication for stem cell transplant. But this, though this therapy is carries a high risk of morbidity and mortality, there are some modified regimens that are being considered in Europe, given that this is an approved treatment that are non-myeloablative, and they're using this for other autoimmune diseases like lupus, MS, type 1 diabetes. It's basically a course of high-dose cyclophosphamide that is followed by autologous stem cell infusion, and the thought process is that it creates an immune ceasefire where the regenerating immune cells are then self-tolerant. So there are some trials that have shown efficacy of stem cell transplant for Crohn's disease specifically. In 2010, 24 patients with severe refractory Crohn's disease saw remission of up to 91% in 1 year. And at the very least, even if they didn't have complete resolution of their Crohn's disease, had a pretty good medication-free survival or steroid-free survival up to 60 to 80% at 5 years. In the few patients that were included in these studies with perianal fistula disease, it was sort of mixed who responded with resolution and who did not, but promising results even in the few people that did. There was one woman who had a severe anovulvar fistula that resolved. 3 patients had sort of a gradual improvement of their fistulae, and 1 patient had resolution of an anorectal stricture that allowed for ileostomy takedown and then preservation of their continence. In 2018, 78 patients were included in the study. These were highly refractory patients. They had failed up to 6 lines of drug therapy. They saw 68% complete remission up in 41-month follow-up. And again, even those patients who did not have complete remission, of those, about 57% of those patients were then tolerant to medications that they were previously intolerant to. So it does allow for either complete immunomodulation or some degree so that the patient then has options. The adverse effects are mainly infectious. Up to 1 year, there are reported issues with bacteremia, UTI, line sepsis, intra-abdominal abscess, pulmonary aspergillosis, and in this 2018 study, 1 patient experienced death at day 56 from a CNV infection. Of course, stem cell transplant is not something, again, that we can throw at every patient, but thinking about the immunomodulatory properties that stem cells can offer to fistula, perhaps there's some benefit in local therapy with mesenchymal stem cells. So mesenchymal stem cells, we think, offer fistula healing through several different pathways. Of course, they're able to differentiate into multiple types of cells. The mesenchymal stem cells that are injected into fistula tracts do this through differentiation into intestinal epithelial cells. They also stimulate myofibroblasts to lay down fibrosis. They generate pro-angiogenic factors to improve tissue healing at the site. They stimulate smooth muscle actin for repair of tissue, and they also suppress the immune response that we think underlines Crohn's disease with suppression of the CD4 T cell and also preventing differentiation of the dendritic cell, which is responsible for the cytokine cascade that occurs with exposure to bacteria in the gut. They can be bone marrow derived or they can be adipose derived. Those are harvested from liposuction, so in high abundance both in those cells and in our population. There is an emerging body of evidence that supports intralesional mesenchymal stem cell transplant dating back from 2005 to present. I'll just outline them here, but again, these are small groups of patients, anywhere from 4 to 200 patients, that shows pretty good efficacy, fistula healing up to 70%, and durable in 1-year follow-up in most cases. This is one of the newer products. This is a quote, off-the-shelf allogenic stem cell product. So previous studies involved harvesting of the patient's own stem cells, either through bone marrow or typically through fat. It required purification of those cells and injection into the fistula tract. This is a new product that is available through Takeda, which is technically off the shelf in that it's harvested from adult donors in Milan and then available to the patient wherever a clinical trial is conducted. It's a single administration that is directed to the site of the fistula. These are courtesy of Takeda, some nice pictures for exactly how it's done. The fistula tract is curetted of granulation tissue. It's then rinsed with saline. The internal opening is closed, and then using a series of 4 vials of this mesenchymal stem cell product, the internal opening is infiltrated with the product, and then the tract is infiltrated with the remainder of the product. There's a gentle massage that's applied to the site and then closure of the external site, and it's kind of a one-and-done treatment. The ADMIRE trial considered this product in 212 patients with complex anal fistulas related to Crohn's and saw very promising results with a combined remission, which is defined as both clinical remission and resolution of the fibrous tract on MRI, both at 24 weeks and 54 weeks. What was interesting about this long-term data is that the combined remission of 51 weeks seen at 51% seen at 24 weeks actually rose to 56% seen at 52 weeks, suggesting that over time there is immunomodulation and fibrosis that is ongoing. Clinical remission is even higher, so even though we see a fibrous tract on MRI, the patient is essentially healed up to 60%, which is promising. The adverse effects of the drug were minor and similar to placebo, which included abscess and proctalgia. So future direction with mesenchymal stem cells is promising. There are several randomized control trials that are in the pipeline, mainly in Europe due to the fact that that is an approved, due to the fact that the stringency for this product is less so than it is in the United States. But the one on top, ADMIRE 2, is starting to enroll patients both in the US and then one center that is active here in California, with the goal to recruit 326 patients treated with an intralesional injection as an add-on therapy to standard of care. So these patients can be your regular patients on anti-TNF or whatnot. Mayo Clinic has put in a protocol that considers delivery of mesenchymal stem cells through a Gore biomatrix plug. They're hoping to get 20 patients, have not recruited one yet. And then the Galen trial is one through the University of Miami, which again is a pilot study, but this is 10 intralesional injections of mesenchymal stem cell, allogenic mesenchymal stem cell. So I hope that down the line we'll have more to offer to our patients than just a bunch of cetons. There are a lot of questions that we still need to answer. Of course, the efficacy needs to be better defined, and how we select patients needs to be better defined. Are we going to consider this as an adjunctive medical therapy? Is this going to be a primary treatment for fistula, or are we going to consider it on patients that have failed several attempts at different treatments, as I outlined earlier in the talk? What's better, allogenic transplant, potentially at considerable cost, autologous transplant, potentially limited to centers that can perform purification of the product after liposuction of the patient. How are we going to inject the agent, and how many times do we need to inject the agent? Of course, we need long-term follow-up data. We need to consider the modality of follow-up. We don't necessarily get MRI fistula protocols on all of our patients. It's typically a clinical diagnosis, but perhaps there's a better role for MRI for follow-up of these patients. And then what is the safety profile of a mesenchymal stem cell transplant? Is there malignant potential in the cells that we inject? All of these things we just don't know. So thanks for your time.